is 12 o'clock, for me at least, so perhaps in the interest of time, we could get started since there seems to be a fair number of people online. So.
And I'm gonna mute for now.
Okay, sounds great.
Yep. Great.
So welcome everyone to our first inaugural Neonatal NIRS Consortium web meeting. I'm Valerie Chock from Stanford. Also as a co-presenter and co-moderator, we have online with us Zach Vesoulis from Washington University in St. Louis. Hi, Zach.
Hi.
And we're also very grateful for Jonathan Mincer, who brought our group together and really, I think at the last PAS meeting especially, allowed everyone to join this, this forum. And I know, Jonathan, you're on service now, so we hope that you are able to also stay on the call with us. I think that this is just a wonderful opportunity. I want to thank everyone for joining. Our goal as this NIRS Consortium is to hold maybe 2 or 3 web meetings a year to kind of talk about how we can move the field forward. And I think all of us have a lot of individual experiences and expertise, and particularly interests using NIRS. Some of us from clinical perspectives, some of us from research perspectives, some from both. So I think we really have a lot to learn from each other, and this is just a great collaborative way to advance the field. That being said, a couple of housekeeping things. I did use a NIRS Consortium listserv to pass information about this meeting on. So feel free, if you know of other people who would be interested in joining, I'm happy to add them to the listserv. Just shoot me an email. Everyone should be coming into the meeting muted. We will have a period of time at the end of the presentations to have a discussion section where at that point, just so we're not talking over each other, what we'll probably do is ask people to raise their hands. So if you haven't used Zoom before, you can click on the participants tab, and then next to your name, there's that little hand icon. So you can raise your hand, one of the moderators will call on you, and then you can unmute yourself and ask your question. So that's how we're hoping this robust discussion period will work. So let us get started. And then definitely let me know if you're having problems with any of the slides. Okay, so as for our agenda today, I'm going to start us off by talking about how we at Stanford implemented a clinical NIRS monitoring program in the NICU. And then I'm going to present a few case examples, as I'm sure we all have, demonstrating the utility of NIRS monitoring the NICU. Then I'm going to hand it over to Zach, and he's going to talk about a few really important research studies. And then we'll have time, as I said, for discussion and planning for future webinars at the very end of the talk. Okay, so here we go. So I'm very privileged to work at an institution where we have a neuro NICU, as many of you also do, where neuro monitoring with NIRS is done clinically for a population of babies at highest risk for brain injury. And this is just a list of who the targeted population that we monitor with NIRS. So we monitor all preterm babies, less than 29 weeks gestation, for the first 7 days of life. And this is because we determine this is the period of time when they have the most hemodynamic instability and are at highest risk for IVH. We can also leave the NIRS monitoring on for longer than the first 7 days if there's active concern for a PDA and if we're thinking about maybe treating it. We also monitor term or preterm babies with severe respiratory failure, congenital heart disease, babies that are pre-ECMO or on ECMO support, and then babies with hypoxic ischemic encephalopathy who may be undergoing cooling. But really, any child where there's a concern for adequate cerebral blood flow is a candidate for NIRS monitoring. And then again, if you're just joining, please remember to mute yourself if you are not already muted. This screen is just an example of the various types of commercially available NIRS devices. We use the INVOS, which you can see here at the bedside. I know other institutions use the CASMED Foresight device. Some may use the non-in device. These are probably the most common, at least in the US. But of course, what I always tell people is, learn to use one system well, including the nuances and the limitations of that particular commercial device, and pay close attention to changes for individual patients. So we always do two-site NIRS monitoring because we find that circulatory impairment reduces somatic saturations first before you see a change in your cerebral sats. So it's an earlier indication of hemodynamic compromise when your somatic saturation changes. So here's just a picture of the NIRS sensor on a baby on the forehead here. Right or left side, sometimes there's not enough real estate to really differentiate right or left. And then here's a renal sensor on the flank, posterior flank below the costal margin and above the iliac crest. Some centers also do mesenteric saturation monitoring. We only do that for research purposes where I'm at, but again, here you can see the mesenteric sensor. There's often not a lot of real estate on the belly either in the infra-umbilical location, especially when there's an umbilical line in place. So people always ask me, how did we implement a clinical NIRS monitoring program in our NICU? And the biggest thing is really exposure. So we started off, I think maybe when I completed my fellowship, with 2 NIRS devices that were being used for research purposes only. But that's how the staff became familiar with seeing the machine and the equipment. And it took, several years of various NIRS projects, and then transitioning it to routine monitoring in a targeted population. So we started off with our congenital heart disease patients. Others might want to start with their cooling population. But broadening the use of NIRS to a targeted population. And then for us, with the creation of our neuro NICU, it was really nice to then be able to monitor a larger subset of babies. And at Stanford, we're quite fortunate in that we have access to a NIRS device for every single bed space. And while not every baby may actually require NIRS monitoring, if they need it, it is available. So it's been very rewarding to kind of see this transition from having NIRS as a research tool only to one that's used in clinical practice on a routine basis. So here's the obligatory picture, baby. I think this is a child that was in our CVICU, lots of tubes and lines, and NIRS monitor sensor in place, and now a happy toddler. Education and training are a huge part of implementing a monitoring program. So I think the nursing staff really needs to be empowered and be a believer in using NIRS. We started off by identifying super user nurses, created policies and a training schedule where all of the nurses were trained to place and remove sensors, chart the NIRS values with vital signs, and educated on when to notify a provider to come to the bedside. And this was very key to the success of our program. We created an educational module for yearly certification of the nursing staff and did receive some assistance from our device reps. Likewise, we also trained the physicians and clinical providers, the fellows, the nurse practitioners, the hospitalists that come to the bedside. And we did this in a similar way through multiple educational conferences. We also have what we call 5-Minute Fridays, which are case studies. We go to the bedside of a baby with a NIRS monitor to really see what's going on and how that tracing might be helpful. The clinical providers also are required to complete this educational NIRS module and an online quiz on a yearly basis. And then we have a nurse educator who checks in with the on-service team if they have any questions on patients undergoing NIRS monitoring. The electronic medical record is also a key component to our program. We have an automatic order set for NIRS monitoring. So for example, the PREMI order set, there are some checkboxes embedded in that for NIRS monitoring. Same thing for those kids that get admitted for cooling purposes. And then it's nice that the NIRS values that the nurses enter get pulled into our progress notes along with the routine vital signs. So a provider can see in their progress note, this is the minimum, maximum NIRS values and mean for the past 24 hours. We also have a system for archiving NIRS files for future research studies and QI projects. So of course, there are a lot of challenges to implementation. For us, I think the biggest thing was real estate on the baby and at the bedside. We were fortunate to be able to kind of move the NIRS monitors off the floor and mount them on these kind of overhanging booms, just like the Philips monitor. So in a way, if you don't need it, you just swing it out of the way. But that was one way that helped to gain us some space in our NICU. Also, of course, cost is a big issue, both the monitor and the sensors. I think another challenge is keeping the sensor in place. I'm a huge proponent of skin care for our babies. And so we utilize Nepitel as a skin dressing, especially on our preemies. Other sites I know use Tegaderm, since the NIRS sensor can still function through that. So we place the skin dressing down first and then place the sensor directly on top of the Nepitel. We've developed a protocol where the nurses check the sensor site every 24 hours, change the sensor out at least every 4 days after dating and timing the sensor. I know some sites like to leave it on until it falls off completely. Others may say a week or 24 hours. I know the sensors are expensive, which is why we just empirically chose 4 days for us. I like to remind people to avoid the direct pressure over the sensor because I have seen pressure injury from, like, say, for example, a tight CPAP plastic piece resting directly over that sensor. And of course, slow and gentle removal. Here you can see a creative way to maintain adherence of the sensor. I think many of us have issues with the sensor falling off, especially in a preemie that's in an isolette under high humidity. We've had nurses craft other things other than this bow here. We've had like little headbands or a soft knit CPAP hat that keeps the sensor in place. And then finally, I like to emphasize that having the NIRS sensors on is not a barrier to holding. We've had moms breastfeeding with the NIRS sensor on their babies, dads doing kangaroo care at the bedside. So it's really nice that we emphasize that point. And then with the Nepitel dressing, since it's more like window cling rather than like sticky adhesive, it can be moved relatively easily without peeling off a layer of skin every single time. And then finally, of course, the challenge is who's paying attention to these numbers anyway. And this is where the education comes into play. If you have a NIRS monitor on a baby, you should be talking about it on rounds to see if it's making a difference in your management. And if it's not, maybe that baby doesn't need to be monitored with NIRS. Okay, most of us are already quite familiar with how to interpret the NIRS, but I'm just going to go over a few quick slides just to illustrate how we train our bedside providers. As many of you are aware, this is the target cerebral saturation ranges as posited by the SafeBoost-C investigators, and this a safe range being between 55 to 85% for the cerebral saturation values, with the danger zone of being less than 40 to 45%, and that being associated with pathologic changes in the brain, as well as MRI and EEG changes in babies. So what we selected was to have a clinical provider notified if there was a sustained cerebral saturation less than 50%. And then the approach to abnormal NIRS values then, when a provider came to the bedside, we really were trying to stress, think of the main physiologic variables that can affect cerebral saturation. So again, quick review, is the baby overall systemically hypoxic? Does that child need to have a higher, the FiO2 turned up? Also cardiac output, maybe the baby's hypotensive and needs a bolus or a pressor started. Oxygen carrying capacity, maybe the baby's anemic. And then what many people forget is the role of hypocarbia. If that baby's overventilated, there may be cerebral vasoconstriction, so that also contributing to poor cerebral perfusion. A few other minor things, cerebral metabolic rate, considering the effects of sedation and controlling hyperthermia, and of course, other underlying conditions like IVH, a significant PDA, or congenital heart disease. And then of course the converse, when you have high cerebral saturation values, maybe there's a supernormal arterial sat and then you can wean the FiO2, maybe there's hypercarbia, or perhaps that baby is not extracting oxygen either because they're oversedated or in the case of our cooling kids, there may be some underlying brain injury. So that in a nutshell is of how we implemented a NIRS monitoring program and how we educated our providers to approach NIRS at the bedside. So what I wanted to do next was just focus in on a couple of cases which illustrate how people approached these findings at the bedside. So here is one preemie where we see a sudden drop in the cerebral saturation here in blue from 70% down to 40% in this one week old. And so we're asking now, what impacts cerebral oxygenation? So the provider is supposed to come to the bedside and assess this and kind of go through those four main physiologic variables that I talked about. So is it possible that this is a systemic oxygenation issue? Could this have been an accidental extubation with a severe prolonged desaturation? Sure, that's definitely a possibility here. Might have taken a little while, however, to remedy that problem. Cardiac output, could that have been the issue? Sure. And we've always seen how when the nurses switch out the dopamine infusion, for example, baby might get hypotensive in that time period. Uh-oh. There you go. Could this have been a prolonged hypocarbic episode with overventilation? Maybe no one was paying attention to the blood gases or hadn't checked one in a while. Sure, that's also a possibility. And then finally, could this have been an acute anemic event, a pulmonary hemorrhage? And that's actually what happened in this particular case. So what we did to raise the cerebral saturation, as you can imagine, we transfused packed red blood cells, and that brought up the cerebral sat very nicely. So again, that was just to illustrate how, this one example, we kind of talked through what the provider had to think about at the bedside. Of course, there are other things going on too that kind of pointed people in the right direction, but it's just a nice illustration of how NIRS kind of verified the problem. So here's the next case. It's a 28-weeker, 5-day-old. And what we notice here in the NIRS tracing, yes, the cerebral sat is on the lower side, somewhat variable, but even more pronounced here is the renal saturation, which is reading 15%. And if you recall, the lowest value on the INVOS monitor actually is 15%. So there are periods of time where the renal sats were even lower than that and not even picking up. So we asked people to think about, what could this indicate? Why is there poor perfusion to the kidneys, to the gut? And so some things to consider. Does this baby have a significant PDA? Possibly necrotizing enterocolitis or bowel perforation, severe sepsis, or even a congenital cardiac malformation like a coarct, which limits systemic blood flow. So indeed, this kid then developed abdominal distension. They got a KUB. And sure enough, it showed evidence of spontaneous ilioperforation, localized necrobowel ischemia. The baby went for an ilioresection and ostomy placement. Of note, mom also had choreo, and the baby was being treated for presumed sepsis. So we know this kid has a very high inflammatory state going on. The child returns from the OR, and this is what the NIRS monitor now looks like. The numbers are maybe a little bit better, especially for the renal sat, but what's a bit concerning to me is the cerebral sat and the renal sat, the values look like they're starting to trend together. So perhaps this baby is not so well autoregulated as we would have wanted. And we know that in kids with NEC, autoregulation or impaired autoregulation occurs, which then potentially sets us up for additional problems. As you can see here, here we superimpose the two images, but the cerebral sat's in blue, renal sat in white. And as you can see, the cerebral sat is dropping significantly and is even lower than your renal sat here. So what's going on? Provider comes to the bedside, goes through all the main physiologic variables, all that looks intact. Maybe this is a significant duct, but the cerebral sat is even lower than the renal sat, which is usually the opposite in the case of a significant duct. So as I was alluding to earlier, you think about, is something else going on in the brain? Maybe this baby might have had an intraventricular hemorrhage. And unfortunately, sure enough, these low NIRS values prompted us to get a cranial ultrasound, which found a grade 3 bleed on the left and a grade 4 hemorrhage on the right. We know that low cerebral sats can be found in babies with IVH, possibly due to excess venous blood in the area of hemorrhage or a low cerebral blood flow state. It is unclear if there's a period of hyperperfusion and impaired autoregulation just prior to the bleed occurring. So I think future webinars might be able to focus on IVH as a topic, because I know we have experts in this group who can speak to autoregulation and strides in that area of NIRS research, possibly maybe even detecting periods of high risk before the bleed even occurs. Okay, I have one last case that I really like. It's a quick one, but I like it. It's a post-dates baby on day number 8 of VA ECMO support for severe pulmonary hypertension and meconium aspiration syndrome. This baby was actually doing pretty well, was weaning on ECMO flow, but then we noticed there, over a 24-hour period, there was a slow drop in both the cerebral and the renal sats. And the child otherwise looked okay. There was no tachycardia, no hypotension, the mixed venous sats and the blood gases were stable, the CVP wasn't changing, there was no lactic acidosis or anemia. So, you know, I think because our team is very keyed into focusing on the NIRS monitor, we were really suspicious that this was evidence of something else going on with the baby. So luckily, we were able to have someone there who is a big proponent of bedside functional echo. And so they decided, let's just see what's going on with this baby's heart. Even I, who am not a cardiologist, can tell that there is extra fluid around the heart that shouldn't be there. So this was a large pericardial effusion that was found. And this baby then had a pericardiocentesis performed with drainage of 50 mils of bloody fluid, followed by uneventful ECMO decannulation. It's unclear if this occurred because of malposition of the venous cannula or some other reason, but what I think is key is that really the NIRS monitor detected the problem before there was any clinical indication of there even being a problem. So the particular attending on for this case was not a huge NIRS believer, but after he kind of saw this, he's like, oh, okay, I'm going to start paying more attention to these NIRS values, because it really helped us in this situation to possibly avoid a more eventful decompensation. Okay, so that's all the slides that I have. I'm going to transition it now over to Zach. I know all of us have a lot of additional clinical cases we can share in the future, but I hope this has kind of whetted your appetite to demonstrate the utility of clinical NIRS monitoring.
All right, thank you. So Valerie's going to keep running the show on the slides, so I'll have her advance it when it's time. So that's a little logistical thing that we'll be doing here. And then it looks like there have been a few people that have joined since we first started the call. So just to say again what Valerie said at the beginning, we'll have a chance for questions at the end using the raise hand button. So if you guys could click on the participants tab down at the bottom, that'll show the list of everybody that's on the call, and then a little button to raise your hand later. But we'll definitely have time for questions. So I was going to go through 3 NIRS studies. I have no disclosures, I guess. I was going to go through 3 NIRS studies from 2019 that I thought were interesting or showed a sort of new finding or were important for future projects that are coming out. I did do a quick Medline search, and there were 37 neonatal NIRS publications in that year, which is actually a little bit less than the past few years, but it does look like it bounces around a little bit. It was a really broad range of topics. So a lot of the early NIRS research was very focused on cerebral blood flow and cerebral autoregulation, but people have moved into a lot of other areas now, which is good. I think that's something that was missing from the literature before. There's papers on neck, transfusion-related studies, procedure-related changes in NIRS, which is a new twist that's come about recently. And then there are several review articles. So if you could go to the next slide, we'll start with our first paper. These are the 3 papers I'll be talking about. So the first one deals with anemia of prematurity and how that changes cerebral oxygenation, particularly extraction of oxygen over time. The second one is looking at a assessment of cerebral and intestinal oxygenation in the setting of NEC, which is something that Valerie was sort of touching on a clinical basis. This is a research study on the same standpoint. And then a procedure-related study. How do different approaches to intubation affect cerebral oxygenation? So for the first study, this was published in Early Human Development, and it deals with a problem that we deal with every day in premature babies, anemia prematurity. This, as everyone knows, is always a topic of discussion. When is the right time to transfuse a baby? Is there an ideal hemoglobin? And certainly something that we don't have an answer for, but not something to be taken lightly either because of the risk of transfusion-associated neck or gut infection, ischemia, whichever particular acronym is in vogue at the moment. And it's not something that's really been addressed very well. So on the next slide. In this particular study, they did weekly NIRS recordings of both cerebral and abdominal NIRS, as well as pulse oximetry. So that, as some of you might be familiar with, there's the concept of fractional extraction of oxygen. So you can calculate what percentage of oxygen delivered by the cardiovascular system is actually used by a tissue. And it's basically the pulse ox minus the NIRS value. So they calculated this particular value as hemoglobin dropped. So they could see the hemoglobin dropping as we would expect for preterm babies, and also saw that the fractional extraction changed with the drop in hemoglobin. You would expect in an intact autoregulatory system that the body would increase the amount of extraction as there was less oxygen delivered. And that's exactly what was seen. So you can see in this scatter plot here, as the hemoglobin drops, the fractional extraction increases. Based on a paper that was published by Alder Leeston out of the Netherlands, we have some nice normative curves of what a normal extraction is. So we know what is considered too low. So once the FTOE goes above 0.4, so more than 40% of oxygen is extracted, then we know that's a danger zone, similar to the slide Valerie showed earlier. So on the next slide, they use this approach to try to figure out what might be a good candidate hemoglobin. At what point on average do these babies drop below that critical oxygen extraction? And it turns out that is higher than many of us generally operate with. So this is 9.6 grams per deciliter for the hemoglobin value where this transition occurs. They corrected for other factors that might be contributing to FTOE, but it still stayed exactly the same in terms of the critical hemoglobin, and had a pretty good AUC for the prediction. And then on the next slide. Moving on to the next topic. So this is how can we use abdominal NIRS in the setting of neck. So as Valerie mentioned, this has often been used in more of a research context rather than the cerebral NIRS monitoring, which is much more established in a clinical context. And something that we really still don't know very much about is how intestinal oxygenation changes both during neck and preceding neck. So how can we use this as an early warning sign? A lot of neck research is focused on things like the microbiome and antibiotic resistance, but there probably is a component of autoregulation of blood flow to the intestines as well. This is a vascular bed that has very low priority in the body, so something that is easily sacrificed in times of stress, like anemia prematurity, for example. So in this particular study, the authors used some animal data that they had published previously, where they showed that pre-neck piglets had higher abdominal saturations and also greater variance. So that the higher saturations as opposed to what we were just talking about, where we're talking about oxygen extraction, these are saturations. So you would expect if not much oxygen is being extracted, the saturations would be too high. And that's what they saw in their piglet model. They also saw a lot of variance, so that the saturations went up and down rapidly with blood flow, also indicating potentially that there was a loss of autoregulation or unstable autoregulation. And they wanted to move this to a human model to see if they found the same thing. So on the next slide, they talk about the study, which was a case control study. So at this particular institution, they do routine NIRS monitoring on pretty much every baby that they have. And so that gives them a very nice library of babies, both as cases of neck as well as controls to match. They used a pretty standard VLBW cohort and then did a lot of NIRS monitoring. So for relatively long recordings for a lot of days. And they're able to calculate both the saturations as well as the oxygen extraction, like we talked about, come up with normative curves, which is something that is not really out there much in the literature. And then look at Kaplan-Meier curves to see exactly at what point the risk of NEC becomes too high. So on the next slide, they show the results. And you can see that the babies who have very low intestinal saturations, which is the complete opposite of what they found in their animal model, were the ones that are at higher risk for NEC. And you can see as that burden of intestinal hypoxia, for lack of a better word, increases over time, the odds of those particular babies having NEC-free survival drops lower and lower. So that's the figure in the upper right-hand corner. They did a similar thing with oxygen extraction, which found the same sort of results. The actual numbers are a little bit different, but the idea remains. And so the thing that was the most striking to me is what's on the third bullet point here, is that babies that had intestinal saturations less than 70% on the very first measurement. So this is not really even a cumulative burden at this point. This is just a single NIRS measurement, had an odds ratio of 9 for later development of NEC. This is a small sample size, so the confidence interval is quite wide on that, but it still gets at a potential underlying mechanism of intestinal vascular dysregulation that predisposes these kids to a risk of NEC further down the line, even if they don't have it at that particular moment. Then on the next slide, I'm going to talk about the final study. So I thought that this was a very interesting paper that was a secondary analysis of a larger intubation and pre-medication group. So it's very well known that intubation is something that is a potential for causing neurologic injury in our babies. There's some very nice evidence that the more intubation attempts you have, the greater the risk of IVH. And that doing intubation without pre-medication also potentially increases the risk of neurologic injury. There's some debate, of course, about exactly what the most ideal group or combination of medications are, but this particular study, they set out to try to compare a couple different ones. So they looked at one group, which they called the atropine propofol group, and then the other one was a more traditional atropine atracurium sufentanil. So one had muscle relaxants and an opioid, the other one was just propofol alone. But one secondary aim that they were very interested in was how do these different regimens impact cerebral autoregulation? In particular, the difference in hypotension and autoregulation in propofol, which they thought might keep where it might be intact, versus the opioid where they thought it might be lost. So on the next slide, they described what they did. They used this for all babies in their NICU. So this was not something limited to term or preterm babies, but they did exclude babies that had other potential complicating factors like airway anomalies or who were already in shock. So things that might influence autoregulation or cerebral blood flow outside of just the intubation process itself. They made a lot of measurements in these kids. So they used the INVOS monitor in this particular study, as well as pulse oximetry, heart rate, and a transcutaneous CO2 monitor, and looked both before the administration of the medication, as well as up to an hour afterwards with a bunch of time points in between. They looked at FTOE at each time point and then looked at the autoregulation. And this was a relatively simple approach to autoregulation where they just looked at the correlation coefficient between the mean arterial blood pressure and cerebral SATs. And then on the next slide, it's roughly equal groups here. So the one in the left column is the fentanyl group, the one on the right is the propofol group. And there was a little bit of a difference in the gestational age and of course birth weight between the two. But the biggest thing was the cerebral desaturations. So babies who received the opioid had cerebral desaturation the vast majority of the time. Almost 80% of those babies had cerebral desaturation versus less than half of the propofol group. Interestingly, even though the saturations were very different, the FTOEs were not, suggesting that the autoregulation in the two groups was relatively intact. and was able to compensate for both of them. That was backed up by the last bullet point on there. The cerebral autoregulation measure, the correlation coefficient between the blood pressure and FTOE, basically were the same between the two groups. They had some very nice figures in this paper, I thought. You can see the fentanyl group is the blue group, the propofol is the red group, and you can see almost right away in that upper left-hand corner where it's just the mean cerebral saturations at each one of those time points. Right from the get-go, the fentanyl group essentially had a lower cerebral saturation. That split widens quite a bit around 15 minutes and then slowly starts to come back together. That roughly parallels a drop in SpO2 that goes around the same time. At least looking at these, although the confidence intervals are wide, it looks like the propofol group does a much better job staying within a normal sat limit compared to the fentanyl group, despite actually having muscle relaxants in that group, which is generally considered to make the intubations easier. And then there's one more figure on the next slide. So this is the trajectory of each of these measures over time in terms of the correlation coefficient. So this is their measure of cerebral autoregulation. And in both of the groups, you can see that the autoregulation was essentially unchanged by either method of sedation. Which is good to know because that's something that is definitely a concern during this very stressful procedure. So those are the three papers that I wanted to present there. I thought they all have very interesting aspects to them and are pieces of things that I think will continue to come down the line moving forward.
So I think now we wanted to open it up to the group for discussion. Any questions, comments, or suggestions, please try to use the raise your hand and then unmute yourself once you're called on. Since we want to have a robust discussion, I'm just going to get us started. Zach, I really appreciated all of the papers that you presented. In that last study, do you think the differences in the two agents, propofol versus opioid, do you think it was primarily the result of the SpO2 difference or maybe the carbon dioxide difference? I'm just kind of curious what your thoughts are on the reasons why we saw those differences in the cerebral saturation.
That's a great question. I think my best guess, although they don't really address it in the paper, is that probably is the SpO2 difference between the two, that those saturations do drop even though autoregulation is intact. It would be interesting if those saturations stayed lower for a longer period of time to see what happened with those cerebral saturations.
Yeah.
That there may be more of a difference over time. This was done in a study context, so I think everybody was paying very close attention, and they probably did not have a lot of junior people trying intubations in that particular setting. But it would be interesting to see how generalizable this is over time.
For sure. I see a hand up from Mohammed. Go ahead. I think you have to unmute yourself. Yeah.
Can you hear me now?
Yes.
Yeah, thank you, Valerie and Zach, for this very nice talk. I think that Valerie touched a little bit about it's very not difficult to have a monitor on each bedside, but the real question is all the providers and the teams are using this in day-to-day management. So I liked many of the ideas that Valerie has put, but one of the things that I want to ask about this educational module and this certification exam, I feel that this could be a very nice tool that probably will be very nice to be shared. because I think this will be the challenge that each center has when they start this program. So I don't know how does Stanford feel about sharing this with new centers and maybe expanding this to be more a standardized teaching and certifying tool for any center who want to use NIRS.
Yeah, Mohammed, I think that's a great idea. I would say that probably a large number of people from this group also have their own cases and examples. And maybe that's something, a collaborative project that we can all contribute to. Sometimes it's nice to see, depending on the equipment your own site uses, how it's really makes a difference. And that's, I find that's very helpful, kind of individualizing it for each center. So, but I'm happy to maybe put forth, we can share some of our educational cases and questions we put together if others also want to do that to make more of a collaborative educational tool.
Yeah, and Valerie, I was going to add something that I think is helpful at a lot of sites is finding champions, just like any early adoption thing, finding champions that are around consistently to help people troubleshoot when they run into issues with either getting it started or interpreting values is really important. And we found, particularly for those of you that are at sites with fellowship programs, the fellows are really good people to use in that role. They generally pick up the ideas relatively quickly, and they're around a lot. They're almost always around. They're there, day and night, and on service for longer periods of time than some of us. So they can be really good partners for rolling out programs like this.
Good point.
Thank you.
I see a hand up from the Sharp Mary Birch people. You want to go ahead and unmute?
Okay. All right, great. Hi, Valerie. This is Anoop, and I'm here with Maynard. We just sort of a question for you at Stanford. Do you still feel like there is equipoise to do a study looking at the impact of using NIRS monitoring for patient outcomes, or are you sort of now just adopting this as, well, this is now a standard of care and not looking at sort of future studies for using NIRS?
Yeah, Anoop, that's a great question. And that also kind of played into a little bit of why we're not participating in the SafeBoost trial right now. But I do think there's still enough equipoise to ask the question, particularly with regards to neurodevelopmental outcomes. I think, we've seen how useful it's been in kind of more the acute short-term issues at the bedside, but there's still that looming question, does it make a difference long-term? So for that point, I think we could still participate in that kind of a study.
Okay, thanks.
Great. Jonathan, you have your hand up.
Yes, can you hear me?
Yes.
So the equipoise question has become a concern for the SafeBoost trials. And there are several centers, both in the US and in Europe, that had to decide that the consent process was going to be too daunting, that the thought was that if certain babies ended up in the control group, they would actually be receiving less care and potentially even less attention than babies who were already being NIRS monitored. However, it's an outcome-based study. What's going to be an interesting secondary data stream from the SafeBoost series, which I can't believe is actually secondary, is what the NIRS data itself shows. So we're trying to put up an ancillary study now that's going to carefully keep control of all the NIRS data itself over time and see how it actually correlates with the clinical decisions that are made for at each individual bedside. I think that may individually have more of an effect on the use of NIRS in real time in the NICU than the outcomes itself, because it guides potentially clinical management in real time.
Yeah, I completely agree with what both Jonathan and Valerie have said. I think that the challenge for equipoise is that I think we all have the sense that NIRS is going to be, either is or is going to be, a very important part of clinical management. But exactly how, I don't think we've really established yet. I mean, there is not, other than SafeBoost 2, there isn't any large randomized trial that's been done. And I mean, certainly we do all sorts of things in neonatology without large randomized trials. That's not stopped us in the past. But something like this, I think we need to really narrow down exactly what we're doing and when we're doing it, which hasn't been answered yet. And sort of like what Jonathan was implying with all this data collection, the thresholds that they chose in SafeBoost are not entirely arbitrary, but they're somewhat arbitrary, and they may not be exactly right. We may find out that we actually need to have a higher threshold for intervention, or maybe a lower threshold for intervention, and that's going to take some time to sort out.
That's a great point, Zach. Jonathan, just since you're talking about SafeBoost, do you want to provide any more of an update? I know some of the people online are participating in it, but is there any more of an update for those of us that are not on how that trial is going or what the status is?
Currently, there are about 25 to 30 centers actively enrolling in Europe and in Asia. Enrollment is moving slowly but picking up speed. There are a handful of centers in the U.S. that are poised and ready, and then there's the grant through the Cerebral Palsy Association Research Foundation that is, if successful, will allow for about seven or eight more U.S. centers to participate. So if we had that up and running, that would that would certainly boost our involvement, on this side of the Atlantic.
Interesting. Okay, I see a hand from Dr. Garg. Can only see the abbreviated name, but it says P. Garg, hand up. Okay, maybe that was in error.
I think there's another question through the chat function.
Oh yeah, that's it. Can you read that, Zach?
Yes, I can. Do you want? It says, we have a specific question on how people are normalizing NIRS data since there's a lot of artifacts in the recording, specifically the splanchnic region.
This is Ed Lagama in New York, Valhalla. Can you hear me?
Yes, go ahead.
So the question we had was, one of the big problems in analyzing the data is the signal to noise ratio. So we're curious what methods people are using to normalize, particularly the splanchnic region, because that has the most variability of all the sites, the brain being the least. So when people report on their data, how are you averaging the information?
That's a great question. Zach, I think you published before on some ways that you kind of looked at your data or denoised the data. Do you want to speak to it first?
Mm-hmm. Sure. Yeah, I think there's two pieces to that question. So one is the issue of norms. So every device and probe combination is going to yield slightly different results in exactly the same patient. There's a whole bunch of studies out there that the Dutch in particular have published using the same device, the Invos 5100C. They get different results, whether it's the neonatal sensor, the small adult sensor, or the large adult sensor. So there's some level of correction that needs to be done just for the device sensor combinations. There's a couple of papers out there where they've actually gone and done all that hard work for us. They've looked at, they have this blood lipid phantom. It's some interlipid, human hemoglobin, yeast, and a saline solution. They inject a certain known quantity of oxygen in it and have applied a whole bunch of different sensor and device combinations to this standardized oxygenated fluid. And so you can correct between devices for the same amount of oxygen. So that's one piece, is those norms. The second is noise, and I agree. This is a major challenge that we face in any clinical data. The babies just will not hold still no matter how much we ask them to. So having some approach to dealing with that is essential for this. There's a few things that we've used in the past, and it's a multi-step process. So the first is removing things that are obvious outliers, and depending on which device you're using, that will show up in different ways. Some devices, like Valerie mentioned, the Invos 5100 can't read below 15%. So if you have a measurement of 15%, that's essentially unreliable data, and that part should be taken out. If you have something that's too high, so a NIRS value that's greater than 100, for example, some of the devices out there actually put in a very large value if there's an error condition. So instead of reporting between 0 and 100, it'll say 82,000, for example, on one of the devices, and you can use that to exclude. So those are the easy ones. Those are the obvious outliers. The trickier ones are motion artifact. And you're right, we've done some abdominal NIRS recording here too, and it is substantially more noisy than the cerebral signal. And part of the question is that actually a difference in the signal itself? Does blood flow fluctuate much more in that vascular bed than the brain, or is this just all artifact? And you can do things like averaging would be one approach, where you pick a time window over 10 seconds or 20 seconds and do an average to smooth out some of that noise. Another approach would be to remove non-physiologic changes. And this is where it gets a little tricky. What we've done in the past with cerebral values is that we've looked at, we have many hours of recordings, and we know on average how much a NIRS signal changes from moment to moment. And a non-physiologic signal is something that is several standard deviations beyond that. So if cerebral saturations change by more than 5% in a 2-second period, that's not something that ever happens physiologically. That's almost certainly noise. So that's another way to exclude values. Once you've excluded those values, that sets up a completely different question about how to handle missing data, but that maybe is a little bit beyond the scope of your question.
Ed Lagam again. Yeah, so I guess there's probably a variety of ways that people have handled that in most of these articles, but they're not always outlined in such great detail. So in a group like this, it seems like we might want to come up with some kind of consensus approach or define some boundaries on how to include or exclude certain data so that we become more comparable in studies where we would all get the same result in the data collection part, and then the experiment becomes the patient, not the technology.
Mm-hmm.
That's a great idea.
Yes. Yeah, something maybe to look for in the future. Valerie, Jonathan, and I are working on something like that right now.
The other thing I wanted to mention, I see Ravi Patel is on the line, and I know his group at Emory, I think there was a statistician or data analyst there that had developed an R package looking specifically at the mesenteric NIRS data. So Ravi, I'm not sure if you're open to talking a little bit about that algorithm that your statistician used. I believe it was and I don't know if Ravi is still at his computer, but there is that option that maybe later we can touch base with him about.
Mm-hmm.
Okay, other questions?
If I could add in over here, it's Jonathan Mincer again. I think I have seen the paper from Emory. It's listed on the archive.org, ARXIV. It's available there if you search for Splanchnik NIRS. It was put up as a public resource. But I think even prior to how a collected stream of data is finessed, or how to remove non-physiologic values and things like that, some of the lowest hanging fruit that we could possibly consider is just what data averaging intervals can be used from one site to the next, considering the brain, considering the kidney, considering the gut. I've also have preliminary data that demonstrates that peripheral muscle monitoring, specifically the thigh, does approximate the splanchnic as a peripheral organ, but it's much less variable. So it eliminates motion artifact and eliminates hollow cavity issues while also providing a peripheral end organ that could potentially be considered a surrogate for gut monitoring when you start to see things go wrong. Now, no studies, to date have correlated peripheral limb monitoring with actual intra-abdominal problems, but I do think that it could be considered a surrogate that in low flow states, the legs could probably be considered as much of an end organ, or probably even more so than the gut would. So there are ideas on this. Moving them forward is going to require consensus, and especially when if we have a large collaborative like this, coming up with a way to make decisions about how we should report our data when it is generated based on what organ system and the known signal to noise ratio within that organ system is something this group can definitely accomplish.
That sounds great. I see a hand from Chris Reed.
Hi, everyone. Thanks for this really great discussion and this collaboration. I just wanted to get people's ideas about, nowadays in terms of our respiratory management, it's moved to a more non-invasive pathway. And I think a lot of the research that's out there is in babies who are intubated. And I think, as Valerie pointed out, some of the interventions that we could make, especially if it's a ventilation issue, are somewhat more limited. And I just wondered if other people had thoughts about, the continued use of monitoring, even in CPAP, or how that may affect some of these normative values that we see in some capacity.
You want to take that one first, Valerie?
I was hoping you would, Zach. Sure. Chris, I think that's a great question. I don't know if I have a good answer for it. I think people have been looking, just the way you said, with non-invasive support and, what the utility of NIRS monitoring might have in that capacity. But I think it's still a fairly open area to tackle.
Yeah, and I think it speaks to having the importance of having a structured approach to NIRS monitoring, just like Valerie outlined in her talk, like what they use at Stanford, where it's a lot of the tendency, I think, is for people to use NIRS as basically a really expensive pulse oximeter and primarily adjust the FiO2 on their bubble CPAP or on their ventilator up or down in response to the NIRS monitor. And what it really is doing is what Valerie suggested, is that it's hinting at some impending other clinical problem a lot of the time when it goes out of range. It's not that the FiO2 is too low, it's actually that the baby is hypotensive, or maybe their CO2 is 15 and they're way overventilated, and that's why their SATs are so low. So using it as a part of a structured, larger program, I think is really, really important. Otherwise, it's not going to really add much value beyond what the pulse ox is already giving you.
And I think respiratory support is such a tricky issue. Like, I know many of us have seen problems where your cerebral saturation is very low, and it's because maybe there's too much pressure from the ventilator impeding blood flow to the brain. And so is that something we can still pick up with a kid on bubble CPAP or high flow cannula? I'm not sure.
Mm-hmm.
Does that get to your question a bit, Chris?
Valerie, I was wondering if you could comment on adhesive versus non-adhesive sensors.
Yeah, it's all about your center and how easily they can get that sensor to stay put. So if your center has found a way using kind of like some of the strategies we talked about, like like a stretchy headband or some other way to keep that sensor in place, then maybe you don't really need an adhesive there, which is partly why we sort of turn to the Mepitel, which is not really adhesive. It's more, like I said, like window cling, but be curious to hear other people's experiences.
So we've used the Foresight Elite monitor for the last couple of years, and they have a neonatal probe that has a built-in headband. You mentioned headbands. So it has a neoprene, I think, a soft foam rubber headband, and a non-adhesive sensor in the middle of it, which we've used for our research studies. For clinical use, we've used things like Tegaderm or Mepitel, and in some babies, we've had success using the non-adhesive sensor and just tuck it under the CPAP hat, as long as it's not too tight, like you mentioned.
Yeah.
That even just the elasticity of the CPAP habit is enough to hold it in place.
Yeah, that's a really nice option. Well, guys, I think it's about 1 o'clock, for me at least, about the end of our session. So I just again wanted to thank everyone for joining and contributing. Hope you found this useful. And I think maybe we will continue to use the listserv to distribute information, potentially about our next webinar. Obviously, Zach and I and Jonathan don't want to be running it all the time, so we may be coming to all of you to potentially lead the next meeting. So thanks again, and hope you have a great day.